Okay, guys, good morning. Welcome to the treatment plan seminar and scientific reviews here at Academy by Yad. We're very, very happy to have you here again. Every Tuesday from 8:30, 8:45 until a little bit after 9 o'clock, we have the pleasure of inviting you to follow our presentations, and then if you are nearby, never forget to come for a coffee and help with our clinical discussion. So today I bring up the 4D occlusal scheme and impartial and full mouth rehabilitation. Today we are going to have a slightly longer presentation because the topic is honestly very, very important. We are always learning with this. And let me just start, as we didn't record my previous lectures, just to say that this is the work of a team, the Yad Lisbon team that we are very proud of, that we have developed throughout these 2 years. Again, let me state that it's never too much to say that we have together made greater things and still a lot to do, and we want to share that with you. This being said, we have three major moments regarding occlusion in implant prosthetics. We have pre-op, per-op, and post-op. The pre-op is related to diagnosis, the per-op related to treatment, and the post-op related to maintenance. This being said, never forget, as in a case report article from a commentary from a colleague in Australia, he says that teeth are suspended in the alveolus. They might be displaced 25 to 100 microns vertically and 56 to 108 buccolingually, which is much more than what you can find in implant positioning and movement, 3 to 5 micromillimeters vertically and 10 to 50 microns horizontally. And this has immediately a relation with how do you handle occlusion in single units and partial units. And just to state that normally, don't forget that the 200 microns occlusal paper will have a contact in implants and in teeth, but in 80 microns, honestly, normally, if you have a clencher, for instance, you shouldn't have a contact in implants as you have in teeth, because the movement of the teeth will prevail over the movement on implants. This being said, you have three consequences of bad planning, and I'm happy to show cases that I've had to rehabilitate, I would say 15 years ago. This is a case of a Spanish colleague that sent me the case. He could not handle the case, and I said, well, okay, send me the models, send me everything, let's see what I can do. And of course, there's nothing that we can do if there's insufficient bone remodeling posteriorly. And at the end, we lack the number of teeth, we lack the process and balance of occlusion, and this is something that we need to be aware. On the pre-op and the diagnosis and the treatment plan, we also have to understand, in another case that I had to change and manufacture an absolute different prosthetics and framework, that we need to have prosthetic space. You have to have prosthetic space in order to reach not only a long-term stability for your implants as a long-term stability for your prosthetics. In this case, eventually today we would treat the case. Of course, here I couldn't do anything as a prosthodontics. I just had to rehabilitate. But normally we should graft the sinus and give more posterior support, and then solve this issue in a way that we wouldn't have a fragile framework that in this specific case, even though it's titanium, it was the only framework that broke on the cantilever after 3 years of usage, okay? Of course, another consequence of bad planning is another case that I received. I got then the pre-op picture, but I received and I had to handle it the way I could. And of course, the oversized teeth and what is called now the FP1 rehabilitations has a lot of detours. It's not as clear, honestly, in this prosthetic field as we feel it is. because not only we need to assess the vertical dimension, as we need to assess the prosthetic space, and we need to assess mainly in the prosthetic space how much and how resistant will be the connectors, or at the end we can have a mechanical failure and a problem. So knowing these three consequences of bad planning, that maybe there are many more, but this is important to say, we get to a point in the full arch rehabilitation in which we have more information, we have a consensus that ITI brought us about the rehabilitation on full arch. And I think we, as a team now, we know this consensus by heart, but never too much to remember that there are 4 factors that really have an importance on the long-term prognosis of the full arch rehabilitations. We have the anterior posterior spread of the implants. Of course, we know now that this is not a discussion about 4, 5, 6 implants, 8 implants. It's much more about the configuration of the arch and how much we have an anterior posterior spread. Then, of course, the cantilevers, the non-existent cantilevers bring up more stability. Then the interocclusal space, which is major important for the initial phase of the treatment, which in fact is what really is closely related with the higher rate of osseointegration and better ISQ final results. And then of course the occlusion, which brings us here today. Another thing that I would like to point out in this pre-op is what for me is what we should have as a mandatory protocol in the clinic, which is the dynamic of occlusion and the evaluation. We have, I would say, 2 major patterns of occlusion. We have an horizontal pattern and we have a vertical pattern. How can we understand this? Well, the horizontal pattern, we have a more range of movement, okay? And we have a muscular and TMJ problem, which are less frequent. We have more dental wear and less gingival inflammation. An horizontal pattern is the one that flows very easily in many directions, with normally a more freedom of the TMJ, and so less inflammatory either in muscles, ligaments, or any other stomatognatic structure. So I would say this brings up, as you can understand, less biomechanical stress. More wear, but less biomechanical stress. Whereas the vertical, you can read the vertical into a less range of movement. For instance, class 2 division 2, very blocked, less range of movement, which brings up more frequently muscular and TMJ problems. You have more fractures and more shipping, and you have more gingival inflammation. So if we have a case with these characteristics, we need to check and we need to understand where that case is and how we will solve it. Normally, as you can understand, the mechanical stress that you have on a vertical pattern is solved by bringing up the case to an horizontal pattern. This is what we do in full arch rehabilitation over implants, which is easier to change. But in partial rehabilitations, we need to look at the rehabilitation, as we said in previous presentations, as rehabilitating the area and the system and not only the implants, okay? So this being said, nowadays we use 4D assessment software that enables us to bring up the quality of the information into a frame-to-frame imaging, which in fact is much more accurate, much more into what we search in a digital environment as the one that we work. This being said, not only we have to check the case if the patient is a fully dentalist, as we have to check the case in a fully dentalist. And here, as you can see, we check the lateral movements as we check as well the opening and closing and the centric relation. And we try to find what in fact is crucial, which is a functional diagnosis. This is what we have to do and what we do in every single patient in implant therapy or in implant rehabilitation. And the risk assessment brings up what we call the 8 critical points, which are midline deviation, vertical overlap, horizontal overlap, anterior open bite, the slide length from centric relation to maximum intercuspation, unilateral posterior cross bite, and medial and lateral intrusive interferences. Any of these in the range of importance can bring up TMJ problems, can bring up instability, can bring up biomechanical issues. So this has to be a protocolized way of looking at our pre-op and diagnosis patients. This being said, on the diagnosis, let's go now to the per-op. On the per-op, we have several articles that can be stated, but I will state two that are closely related to the subject itself of occlusion. The first one is from Gohl in the Journal of Prosthodontics 2012. He considers at the end that the micro movements exist until a certain limit of force. So we can accept that in the beginning of the immediate loading process, we have some micro movements, but we cannot overcome a limit of force. That is closely related, of course, with the insertion torque of the implant, but in more detail and more precisely with the ISQ of the implant. So if we overcome that ISQ, we eventually can change what is the actual osseointegration process of that implant. Then splinting is a good idea in immediate loading when we have more than 2 implants. This, in this beginning, will of course diminish the momentum of forces, and this being said, helps bringing biomechanics into a less risk situation. The insertion torque, this is stated by the article, at least 13 Newton centimeters. The conclusion is we need to have inter-arch stabilization, or if we are talking about the same arch, we need to have a good contact point stabilization. Not only we need to have the screw retain prosthesis, but of course search for a good contact point, which brings up stability as well. The provisional material is also important. We use here an Accident, which is a very, very good acrylic material with less monomer, so good stability, good resistance to load. Of course, screw retained is also a good conclusion. The correct occlusal contacts seems very common sense, but is very important as well, and the number of implants in this article is stated, whereas, as we said and looked before, is not as important. Then I bring up another article that was written to, at that moment, 2007, to prove and to try to answer a big discussion that was related with the cantilevers and tilted implants, etc. But let's point out what is important for us in this article. Of course, Bo Rangert, which was one of the mechanical engineers for a long, long time, one of the most known in implant dentistry, he just studied and he just looked at a finite element analysis over implants loaded on a cantilever, sorry. So the stress in the bone is lower when they use tilted implants. This is what the article says. But let's forget the tilted implants for a second, and let's look at this with the data. So there's a load of 50 newtons that is given to a framework over two vertical implants, okay? As we tilt the implants in the same length of framework, as you can see, there's no statistical evidence or difference that could be stated as really important. What for me is really the point that I want you guys to have in mind and bear in mind as an image is this one. When the framework doubles and the load of 50 newtons is on the tip of the framework of the cantilever, as you can see, you have 60% more load and more stress at the implant head of the implant that is closer to the cantilever. So guys, this for me is a major information, because then as we go through the article, they want to state that the tilt implant is blocking and getting back to the levels of the previous data that they had on a single framework. But what you need to know and maybe understand here is that if we would support this framework differently, forget if it's tilted or not, the results would be the same, okay? So the issue here, we need to avoid cantilevers. We really need to avoid cantilevers. On the post-op now and finishing, we have to not only do an occlusal control and the maintenance, but as well check and compare what was the pre-op and how much we have solved the condyle path and the interincisal points, because this is what will bring your case to stability throughout time. It's not the aesthetics, guys. It's not the, of course the biology is super important, and this is something that oral hygiene will maintain after the surgery has proceeded accordingly to their expectations. But the prosthodontics has to have a major impact and focus into bringing this into stability. This is really important and massively changing what was the recordings on the pre-op, okay? And finishing with this important article from the Michigan team, the University of Michigan, the Occlusal Considerations Implant Therapy. This is an article that I would say is like mandatory to read, because it didn't change too much. You have several articles that have been published throughout time, of course, trying to check if something has changed. And one of the conclusions that this article states is that we do not have today any evidence of an occlusal pattern that is better than any other. And why? Because every case is different. That's why the diagnosis is so important. The assessment and risk assessment of the functional diagnosis is so important. And this is what brings the case into individualized and customized approach, okay? But let's go into specific ways of stability occlusally. In the full arch, you have bilateral balanced occlusion or group function if you have natural dentition, okay? We here at the Ad Lisbon, we try to have mutually protected occlusion, which brings up to posterior support with no anterior overload and anterior guidance with no posterior contacts, so that we try to mimetize what is a natural dentition. Infraocclusion in cantilever segments, we have talked about this. This is 2005. Now what we do here is, of course, we search as a team to non-having cantilevers, okay? Freedom in centric, I think it's important, but is the freeway space. We want to bring the freeway space to an unblocked situation, and I think this is what actually brings the immediate bridges into an occlusal stability and non-urgencies at the clinic, I mean. On the posterior fixed prosthesis, you just fix the anterior guidance with a natural dentition. And you have centered contacts. Very important to have narrow occlusal tables, okay, and flat cusps. In prosthetics over implants, you need to diminish the momentum of force and the blockages to the movement. So let's not point out to over deep cusps because this will not bring up the stability in our opinion and from this article as well. Then in single implant prosthesis, of course, what we will have is we will use a natural dentition to get stability to our single implant and single unit rehabilitation. And what we have to know is in specific cases like this one, it is crucial that we have an annual control so that the occlusion can be checked digitally every year and we have enriched the good stability of the case throughout time. Having an 80 microns occlusal paper on teeth that contacts and not contacting on the implant. So digitally, of course, we have to check the clearance, and the clearance have to have the green area on implant and red area on teeth, okay? So we are finishing, and just finishing with, with the poor quality of bone or grafted bone. Now we use the ISQ levels to assess if it's time to rehabilitate. So this brings up a relation to what the article states, which is longer healing time if that's the case, and progressive loading if that's the case as well, okay? Because what we want to have is not only a patient that is able to get his immediate loading in place, but as well having a stability in the long term. What they talk about staging diet is in grafted cases, we have to be more strict. In big grafted cases and full arch, we have to say, in the next 2 months, you should have soft foot. We cannot consider, so to say, that a patient that has been through a much more technical and difficult procedure and specific procedure has any risk as any other patient that in orthopedics has, as myself, ripped the Achilles tendon, starts rocking the stage and dancing like crazy after 1 month. It's not possible. It's just not possible. And we have to consider and accept this. So guys, thank you so much. Oh, sorry, still this, sorry. Só para ver se estavam atentos. Again, this is an article that I will share with you guys, but in implant occlusion, you have an increased support area, improved force direction, and reduced force magnification. This is the objective of the implant occlusion, okay? And you have, of course, all the details here that can be assessed, and I'm very happy to share not only the PDF with the team, but the article itself if you need. Of course, what we have understood is an improved force direction, a shorter occlusal force, a long implant axis, centered contacts. This is really, really important, mainly in unitary rehabilitation, which in fact is what we are talking in a lot of cases that rehabilitate here, okay? So guys, thank you so much. I hope that you liked this presentation. This was about the 4D occlusal scheme in implant dentistry. A little bit longer today, but we had to state pre-op, per-op, and post-op. Thank you so much. See you next Tuesday. Bravo, 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 bravo.